So Dr. Mahua and Dr. Vijay, we will start with the webinar now.
So we are good to go, right? So I can start.
Yeah, we are good to go.
Yeah. Hi. So a very good evening to all of us. And thank you so much for joining us over here. And so to start with, when the entire marketing team and the head of marketing, Abhishek, they came up with this idea that since the proof of the pudding lies in the eating of it, why not? For all the endeavors that we have done with the technology and the test that we have created and taken as an offering to the market of infectious disease diagnostics, why don't we hear it from the experts and from the early adopters of it? So this was a very interesting idea for me. And the first name that cropped up when we were trying to figure out who should be the one who pilots this series of webinars that we are going to have, there could not have been a better name than Dr. Vijay Kulkarni. So let me introduce, and it's a privilege and honor for me to introduce Dr. Vijay and to hear from him his insights of the journey he undertook. Now, what was very interesting for me, and this is an anecdote I would want to share with all of you, that while he will be elaborating on how he took some of the decisions and how things went on to play in his laboratory and changed the landscape of infectious disease diagnostics in his city. When I first met Sir, I would definitely say I have not found a more humble person, because the more we came to know about him, the more impressed we were. Dr. Vijay, who is a medical microbiologist, he's a specialist, and he was the first one to have introduced the concept, the importance, and the absolute clinical necessity of having a robust clinical microbiology diagnostic division in the city. So his was the first of its kind laboratory in Kolhapur. He introduced all the leading technologies. So every time there was an advancement, he would be the one to bring it to his city. And he set an example for not only his city. We found out that his name travels far and wide across the country. So when people in Trivandrum and Kochi also recognize him, uh, right from the word go, it's very encouraging. Apart from that, he has the title of an Iron Man. It is never easy to actually establish technology. And I think Sir not only has managed to ace the triathlon, he has actually applied it in real life by being a real Iron Man, facing all odds and making sure that advancement wins in his field of expertise. So, before we hand it over to Sir, today's discussion will be around how a test which was designed to shape the future of clinical microbiology detection methods, how it has challenged conventional diagnostics, how it has improvised and overcome the limitations by being culture free, by being straight from the sample, by being something which can deliver the most comprehensive pathogen detection within 24 hours of sample receiving, how it has been a technology which has been transferred from the ivory towers of research to mainstream clinical diagnostics by a man, by the adoption of something which we very proudly call the Genomic Centers of Excellence, GCEs. So we started off with GSCs, Genomic Sequencing Centers, and then this was a fresh nomenclature, Genomic Centers of Excellence, because we realized that it was people, it was drivers like Dr. Vijay who actually made these centers of excellence, who were able to deliver clinical grade genomic reports with their powerful insights to patients for better outcomes, for shorter hospital stays, and for better antimicrobial stewardship practices in different corners, in every nook and corner of their city. So yes, this is something as a concept that we have brought, but the success of this concept was just made possible by people like, and doctors like, and pioneers like Dr. Kulkarni, who adopted the system, who set it up at their place, who made sure that this advancement is available with everybody um, as a use case. So over to you, sir. I think anything else that I speak is going to rob you of the thunder, so I will not. So the rest can be elaborated. I think we can stop sharing the screen, and sir can take over from here on.
Very much, madam, for the kind introduction. I'll just share the slides. Is it visible now?
Yes, sir.
Thank you very much. As Mahua madam rightly said, I started my laboratory, micropath laboratory, almost 22 years back in Kolhapur. So it was first kind of a microbiology laboratory in Kolhapur. So people were means clinicians were not getting uh, that quality of microbiology reports like culture and sensitivity. So I started with my practice, and then I went on discussing with the clinicians the results and reports of the culture, and that's how I went on introducing newer technologies in Kolhapur, so third tier city. So here, then actually, since last I will say 6 to 8 years, I also introduced BioFire in my lab, and then we started using BioFire. So multiplex PCR was also introduced in Kolhapur 6 to 8 years back. Now, uh, last year I went for a conference in Mumbai, and I heard the lecture of Mahua madam, and I was quite impressed with the technology that something like genome sequencing can be applied in clinical practice. So I went there. There was a stall of haystack. I went to the lab in Mumbai, their lab, and I saw everything, and I was quite impressed. And I thought whether I can start this in Kolhapur. So although the task was a big task, and actually uh, I was I was not means sure whether I can start it in Kolhapur or not. But the hashtag team, they supported me like anything, and we could start it. Actually, this NGS was even new to me. Actually, we heard this NGS before during COVID times that by using genome sequencing, people are detecting different variants of COVID virus and all that. So then I came to know that this when I met the hashtag people, or then when I met Moa madam, I came to know that actually this can be used in the clinical practice, and it's very useful for the clinicians. And we are going somewhere beyond the just multiplex PCRs. So even though people are using multiplex PCR, they have there are some you can say limitations. Some 30 to 35 to up to 40 pathogens we can detect. But here, when I went through the this reporting of this NGS, I I I saw that there are no boundaries for the detection of bacteria and fungi and viruses. So even a few of the names we have never heard before, those bacteria are also you can get when you do the NGS test. So as this slide shows, we can detect all bacteria in the NGS, all fungi, many of the respiratory and neuropathic viruses, and most important thing is we can detect the antibiotic resistant genes. So these ARGs can also be detected by using this test. And here it is actually what it is written here is very much applicable. It's a culture-free detection. you will get the report within 24 hours. Broad pathogen detection means bacteria, fungi, and viruses, as we have seen, and co-infection can also be detected. That means many of the times there is a polymicrobial infection, and uh, many tests may not identify all the pathogens together. So, but here by using NGS, we can detect these multiple pathogens in a single test. That is a very good thing that we can offer to the clinicians, and actionable insights. So, treatment decisions may definitely change when we get this polymicrobial infections. Yeah. So this is what we have adopted is a Genomic Center of Excellence, that is GCE model. So it has integrated workflow, clinical and scientific reporting is there. So all these things, NGS technology, advanced NGS technology, and mainly automated bioinformatics software is there, which is generating proper or reading the signatures of the bacteria, viruses, and fungi, and it is giving you a very good report, which is clinically relevant, especially. Now we all know that these infections are harder to read. Means most of the time they have polymicrobial infections, and many of the immunocompromised patients, they show atypical bacteria. So routinely in culture there are limitations. We can cultivate very few bacteria. Why I'm calling very few bacteria is I was thinking ki so many bacteria we can grow on cultures and on this media and all that. But uh, when I started using NGS, I came to know that they were very few in numbers. When uh, we compare these NGS reports, okay. So many rare organisms, atypical organisms we get, and actually they are very helpful because many a times we report many of the clinical samples as sterile. So actually, we don't know whether they are sterile, and also there is a problem with antibiotic inhibition. So many of the times, patient is on antibiotics, and we cannot grow many of the bacteria. Even though on gram-stem sometimes we see these gram-negative or gram-positive organisms, but we are unable to grow them. So again, we report it as sterile. But here that also is overcome. So in NGS, even we can grow these antibiotically inhibited bacteria. So that is one of the greatest advantage of this NGS. Now, what are the so yeah, in the same thing, we are using different, as I already mentioned, culture, serological diagnosis, antigen tests, different multiplex PCRs, and all that. But these fastidious organisms, atypical organisms, rare organisms, they are often not grown on the cultures. And the clinicians, they need answers. So they need answers sooner. So even though we can grow many of the bacteria in cultures, it is going to take more than 48 to 72 hours. So by using NGS, we can report it within 24 hours, and the patient can be put on the or started with the proper targeted treatment. So I already told that I thought of starting this NGS GCE, that is Genomic Centre of Excellence. Then uh, we started it, but initially there were hiccups. So it was not easy for the clinicians to digest the report of NGS, or it was very difficult for me also to explain them, because this NGS technology is entirely new to all these clinicians. They were unaware of the this technology. So uh, we started giving reports. I started discussing one to one with the clinicians. Then we took so many RTMs. Uh, so that is roundtable meetings. Uh, they were hospital meetings with all the clinicians in the multi-specialty hospitals. Then many of the societies, clinical societies, to whom we delivered the lectures, and mainly I included the positive findings, clinical cases which are very much useful for them in their treatment. So that I presented to them. So here, first clinical success that I got, this there was a 14-year-old female. She got a abscess, submandibular abscess, and that was aspirated, and we cultured it, but it was completely sterile. There was nothing was there in that, and I I told the clinician that whether we should go with the NGS, it will be helpful to the patient. So he agreed, and we did the NGS, and it was Bartonella henseli, which is a causative agent of cat scratch disease. I think we had heard it only in our during our college times in the books. We have never seen the organism. So many good clinical cases I got, and once I reported it that it is a Bartonella henseli, he was very happy. They started treatment accordingly. It needs actually a long-term treatment. So the definitely that patient was saved because she was a 14-year-old female, and if inadequately treated, she must have got some discharging sinuses and all that on in the submandibular region. So it was very helpful for the patient. So that was the first case, and I presented in many of my presentations. After that, we started getting referrals, and one by one, whenever I used to get a good report. I used to discuss it with many of the pulmonologists and many other people. So they were also quite impressed. And then the journey started. People started sending samples, and nowadays they are getting very good results. There is a good referral for NGS, and we are expanding not only in Kolhapur, but we are getting samples from nearby districts also, like Sangli mirrors here from Ratnagiri, Sindhudur, and even from nearby districts like Belgaum district. So we are getting referrals from all these places right now. So this is one of the case in which BAL sample was submitted, and we could get so many organisms, but one of it was Mycobacterium tuberculosis. Actually, it was clinician was unaware of the Mycobacterium tuberculosis. It was least suspected, and there was no any other tests revealed at that time. So whenever we reported this Mycobacterium tuberculosis, along with aspergillus, it was a polymicrobial infection. So dual infection. So patient was started with uh, antibiotics or AKT and antifungal drugs according to the diagnosis, and it was very helpful for the clinician. In another case, it was again a swab or nasopharyngeal swab in which we could detect this comprehensive respiratory panel or pathogens we got, that is COVID-19 virus, herpes simplex 1 virus, and Haemophilus parainfluenzae. Uh, Haemophilus influenzae is included in many of the multiplex panels, but parainfluenzae is not there in many of the panels. So it is again a very good diagnosis that we made. It was again a polymicrobial infection, and patient was accordingly started with the treatment. So this GCE model, that is Genomic Center of Excellence, has given us a lot of, it has helped us a lot in establishing ourselves, our laboratory, giving good results to the clinicians, and even along with genome sequencing samples, all other samples like routine cultures and all that, they are also, we are getting good referrals. So actually this GCE model helped us a lot. So we are getting almost samples from more than 40 hospitals and other you can say other healthcare centers. And people are very happy as we are giving the reports within 24 hours. As initially it was thought that whether we should transport the sample to Mumbai and then give the report, but again it was not at all possible. It was getting too much time. That means one day for the sample to reach at Mumbai, and then another day for processing. So almost again 48 to 72 hours were required. And whenever we started this GC model in Kolhapur, we could deliver the reports within 10 24 hours, and it was very helpful. So these are some of the hospitals which are sending samples to us. There are very few, but these are the major hospitals that they are sending samples. So Aster Radha Hospital is there, Mira Civil Hospitals, Alliance Hospital, okay, Sidgiri Hospital, which is a neurosurgery unit, Bharti Hospital, Apex Hospital, etc. So many hospitals are sending samples to us. So in this slide, so I think I already explained this. So discussion with the clinicians was the mainstay in this. So whatever the result I used to get, I used to discuss with the clinicians and looking at the clinical picture of the patient, we used to correlate the result. So that helped me a lot. And we, of course, it was a great success for micropath laboratory. And we have started getting a lot of samples now. So thank you very much.
Thank you, sir. That was so brilliant. It's so encouraging and inspiring, and I'm sure our participants would feel equally inspired. A few things, sir. If I have to ask you now that you have the test with yourself, if somebody gives you two propositions, one where the test is at a central laboratory, you are sourcing samples to that place, versus adopting technology and keeping it near point of care. Now you have really done it. You have experienced the entire operations and met all the challenges of setting it up inside your space. Which one would you prefer, the hub and spoke model or this democratic model?
Definitely, this DCA model is always better, madam, because as I've told just now, it takes a little longer time to reach the sample to Mumbai and then processing, and then we'll get the report. Then we have to discuss with the clinicians. But here, what happens is, as we are processing it here only, actually the clinician they need the reports as soon as possible, as fast as possible, because they need to start the treatment, definitive or targeted therapy, as soon as possible. So always it is better to do it at your place so that you can give it the report within 24 hours. And one more additional thing that happened is whenever I started doing it here, and analyzing the reports and discussing it with the clinicians, that helped me a lot. Means initially before starting the test, people used to talk to me that this is such a case, and we are about to give this sample to you for NGS and all that. So during that time, I used to get some idea that what is the kind of sample and what are the possible things that may come out, and then we are correlating it with the NGS report, and then again discussing with the clinicians. So that helped me a lot. So it is always good to have it at your place, and your hands-on is it's very useful and helpful. Yeah.
Yes, sir. Had I now been a practicing clinical microbiologist, I would have also wanted it for my center and to own the test myself. I think that is very valuable for any clinical microbiologist. I think, sir, you are very right when we think of us as a bridge between the testing processes and the bedside. As the bridge, we need that maximum information from both ends, right? From how the sample was sourced, all the pre-analytical conditions being maintained, the actual processing. If it is under our supervision, it gives a higher confidence in the processes that were employed, the correctness of the analytical processes, gives a very tight control over quality. So much so as to say, and of course, what you mentioned, the most important part, the clinical correlation of the report. So otherwise, it's just a page. The second thing I really want to ask, sir, is what was the situation of fungal diagnostics before and after this GC with the enablement of infection NGS in your city?
Question, madam, because it helped me a lot in fungal diagnosis. Actually, initially it was, we used to do fungal culture and KOH mount examination. So many times we may not get the fungi in KOH mount examination. We have to rely on cultures. And fungal cultures, as you all know, it takes very much time. It's 6 to 8 days at least it takes for the filamentous fungi to grow. So our report used to go after a week to the clinician. So by the use of genome sequencing, within 24 hours we can detect the even filamentous fungi like aspergillus, mucor, etc., and we can report it directly. And even it has the advantage that we can identify whether even the candida and its species, whether it is candida albicans or non-albicans candida, even we can detect candida auris in this. So that has become very helpful because if we do the culture and all that, then we have to grow these fungi, we have to grow the candida, and next day we have to go for again identification and all that. So the second means within 24 hours we are going to give the definitive which candida is there. That also can be reported. So definitely it is helpful.
Sir, now for every city in the India, you can also envision that fungal diagnostics will change in a huge way if this test is made available. At least if there is one running center in every city, it will ensure that fungal diagnostics will improvise a lot. You do see a burden of that infection in the burden is there. I think diagnostics need to improve
It is there.
in every
Yeah.
city. Sir, how has this? You found real clinical utility in the pathogen identification. What I could understand from what you mentioned was, while we all along, like all our lives, we have depended on culture. With the advent of this technology, we realized that there is so much beyond what we can grow. So we were actually blinded to the entire iceberg. We were just looking at the tip of the iceberg, probably. And every clinical microbiologist, every ID specialist, every intensivist will be more empowered because now they will know what is there and then they can correlate clinically. In this entirety, sir, while pathogen identification remains so important, what is your take on these resistant genes that now you are seeing and how it has helped conversations with the clinicians?
Yeah, definitely. Nowadays, the treatment in the ICUs, it mainly depends on detection of these antimicrobial resistant genes, and accordingly, people start with or they either escalate or de-escalate the treatment that is going on to the patient. So, reporting antimicrobial resistant genes within 24 hours, again, that is a real advantage to the clinician who is treating clinician. See, because in normal course, we have to grow this bacteria. It will take 24 hours in culture and all that. And then we go for detection of these genes by many methods, like genetic method is also there, or immunochromatographic method is also there. So then we go for that, and then we used to report. But here, within the same test, we are giving the report. That is really advantageous, and people are very much using it, and it is very much helpful to the clinician.
So the last thing from my end, then I'll open the forum for discussions. If you have to give a one-line message to anybody who is an owner of a laboratory or a hospital or who is a key decision maker in any center, if you have to give a one-line message to them for the adoption of this test, what would you want to say?
I would like to say, just adopt this technology, genome sequencing, and you will see wonders.
Thank you so much, sir. The forum is now open for discussion. I welcome Bhavna ma'am, and Bhavna ma'am is from Medanta, Lucknow, sir. And what she has asked you is your experience with bacterial septicemia. So I think blood as a sample. She wants to understand your experience with blood being used for this test.
See, just like I told earlier, I was using since last 6 to 8 years, I was using BioFire. But still in BioFire, whenever we have to use this test, if we are going to use blood, there is no any panel to directly use blood for this multiplexing. So we have to grow them in a culture, blood culture bottle, and then we have to use that as a sample, and then we can go for the BCID panel in that. But here in genome sequencing, directly that blood sample that which is collected in a sterile vacutainers, that directly can be used for the genome sequencing test, and that is really helpful, and definitely will get uh, reports within 24 hours by using this. It's really helpful.
Sir, if you can remember any particular case or the kind of findings that you had in blood, maybe it will be a good insight.
I have got few of the salmonella cases. Even in septicemia cases, I have got Acinetobacter and Klebsiella. So we have detected them. They were even many of them, they were NDM, and few of them OXA48 producing and all that. So we reported it within 24 hours, and it was very helpful.
Thank you, sir. Ma'am, I hope it resolves your query.
Hello.
Yes, madam.
Yeah.
Hello, ma'am.
Thank you so much, Dr. Vijay, for such a nice presentation. I just actually wanted to understand if you get cones and if you get, any of these bacteria, frank pathogenic bacteria. So, how do you actually differentiate between this contamination and the pathogenic? I mean, it is not semi-quantitative, is it?
Actually, it
And
is.
most of the time, what
It
I
is.
presume that you must be getting cones or something else. So it becomes very difficult to identify whether it is a frank pathogen or not.
Yeah. It's a very good question, madam, because whenever you see a NGS report, you may get three or four organisms in that. Sometimes it all depends on the sample collection. If you have collected the sample specifically with all the sterile precautions, you are going to get definitive diagnostic pathogenic organism in that. But if there is collection contamination, some environmental contamination, so you may get other pathogens also. In that case, what is helpful is to a dialogue with the referring person or the referring clinician. That is very helpful because being a clinical microbiologist, we know some symptomatology and all that, and we can correlate the things with the patient status or patient symptomatology, and then actually we can discuss with the clinician that these are the organisms. And see, I will tell you one case that today itself I got. There was an old lady who was she was admitted in a multi-specialty hospital, and I got a.
Hello.
Ma'am, I think there was some network issue.
Yeah, at his part, right? I thought it
Yes,
is
ma'am,
at
I
my
think
part.
so. I think so.
Yeah, yeah, yeah.
There is some issue from Dr. Vijay's side. He will be joining in like a minute.
Thank you.
Yeah, am I audible now?
Yes, Dr.
Yeah,
Vijay.
yeah, Dr. Vijay.
So I discussed the thing with the clinician, and finally we came to the conclusion that the culprit was Streptococcus pneumoniae. That is, pneumococcus was causing the pneumonia in that old lady, because these other two bacteria, they were commensals, and they were not even they were not showing, even though it was Acinetobacter baumannii, it was an environmental strain, because it was not showing resistance to any of the antibiotic resistant genes. So that way we can communicate with the clinician and we can discuss the report, and definitely this has helped me a lot, because of NGS, even I have started talking or discussing more with the clinicians, and that is again one more additional this thing means good thing to me, for me also.
That's great. That's great. Actually, it is a very, definitely a very good technique and very advanced technology, which should be useful. But the only thing which I am a little bit, worried about is the blood sample, because blood in itself is an inhibitory for all these molecular techniques. So I was not very sure that how much it is useful in case of septicemia. uh, what is the percent positivity in your center for the blood samples?
Not calculated it, but because blood samples, we get lesser number of blood samples actually. And again, whenever we compare it with the blood cultures, uh, it is actually, if that, see, again, when we do the blood cultures, it is always said that you have to take two samples at a time, and again you have to repeat it again. So that is why it is said that the bacteria should be there in that portion of the blood that we are collecting. So that is again applies here also. If bacteria, they're present in the portion that we have collected, and if there is a frank bacteremia, then definitely we are going to get the this thing growth or identification in the NGS report. That is
True,
there.
true. Hmm,
Yeah.
true. Yes. Thank you. Thank you so much.
Thank you, ma'am. And I suppose, ma'am, like I have spent 3 years with this. I think Dr. Vijay has spent, he's going to celebrate his first anniversary very soon with this test. I think it is just maybe the routine use, knowing the patients, and that gives that confidence of how it is going to be useful. I'm sure, ma'am, the day this test is on your table and you are conversing with the clinicians, you will have the insights for the center and the
Yeah.
use cases
Hmm.
defined, and a lot of value addition to the test as well with your expertise.
Definitely, it should be. Should be.
Thank you, ma'am. Thank you.
Hello. Yeah, good evening, Dr. Vijay. Can I talk?
Yeah. Good evening, madam. Please.
Yeah, I'm Dr. Sunitri. I'm a pathologist. I just wanted to ask you, was there a situation wherein the routine culture has given some other organism and your NGS has reported another organism? Was there a situation like that anytime?
No, I don't think such thing has happened, because actually whatever there in the culture, you have grown in the culture, that will definitely, that is going to come in the NGS. But again, we are getting a few more inhibited bacteria if they are there in the NGS report. So actually, along with that organisms, we are getting one or two other organisms if they are present in the sample. So that is
Mhm.
again
Will you,
advantage.
like how will you be giving the a report, like which organism is more in number and like which is actually more in abundance and all? How are you going to get
There
the
there
report?
is there is a semi-quantitative method that is used in the NGS report. So
Mm-hmm.
there are reads that are reported. So that is something like reads that is there. So number of reads that are there. So accordingly, you
Mm-hmm.
can guess the quantitation of the bacteria which are present.
which organism is predominant.
That
You
can
you will
be.
report it. Okay. 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 Thank you. Thank you, Dr. Vijay.
Do we have any more queries for sir? So if not, then maybe we can wrap this session. Heartfelt gratitude to you, Dr. Vijay, for sharing your experience, your insights, and now your journey with this particular test. I think this test has also managed to bridge the bench and the bedside, because now the clinicians and the clinical microbiologists are talking more often than they used to. So that is brilliant. Another purpose served, I think, which we had not imagined so much. So thank you for that insight as well. And thanks to all the participants. I think I'll go with what Sir has mentioned. Go for the test, adopt it, please. And I'm sure you will have your own set of understandings, insights, which you can bring to us. We are always looking forward to your suggestions, your inputs. And we are there to resolve whatever queries and whatever add-ons we can for this test. So thank you, signing off for today, and please watch this space for more such insights from people who are on the forefront, who are the early adopters, and I call them the brave hearts. So
Thank you
congratulations,
very much,
Dr. Vijay.
madam.
Thank you.
Yeah, thank you, madam. Thanks all.
Good evening
Thank you.
and have a great evening, all of you. Thank you. Bye bye.